Good evening, everybody. Welcome to our weekly Cerebrovascular and Skull Base University of Miami Symposium. This is now the 27th in a series on November 19 today. I'm Jacques Morcos, professor and co-chair of the department and director of Cerebrovascular and Skull Base Surgery. Co-directors of this course, Carolina Benjamin, assistant professor, director of our Keynes Dissection Lab. Carolina specializes in brain tumor and skull-based surgery. Mike Ivan, assistant professor in my department. Mike is director of research at the UM Brain Tumor Initiative. And Mike specializes in brain tumor, skull-based, and epilepsy surgery, as well as my two endovascular, open vascular partners, Bobby Stark and Eric Peterson. It's been a wonderful series of weekly seminars. Of course, we're beaming to you from beautiful Miami. Our two hospitals are University of Miami Hospital and Jackson Memorial Hospital. I encourage you to write your questions during the session in the Q&A box. We will probably address them between the speakers. We will see how today will be a little different because some of our panelists may need to leave early. We are not offering CMEs. I'm asking the speakers to speak about 20 minutes so we stay on time. This has been the recent series of sessions we've had. We are here today, and you can see that we really only have 3 more to go. And we probably will not continue doing this weekly in 2021. We might move to monthly, but I will let everybody know. Of course, next week is Thanksgiving, so we're giving you and taking ourselves the day off. For December 3rd, though, please, this is wrong. It's not next week. It's December 3rd. Thursday, December 3rd, we'll have the 3rd series of complications of neuroendovascular procedures. We're doing a total of 4 in a row. So don't miss that one if you're interested in vascular. We have a fantastic panel, as you can see. Our pediatric colleagues are doing, I have started a series on Monday evenings at 5 p.m. Co-directors Toba Niazi and Heather McRae. So if you are interested in pediatrics, please join them on every Monday at 5 p.m. along with co-directors John Ragib and Shelley Wang. Many thanks to the team here in the University of Miami that makes these webinars happen. The wonderful work that they're doing, particularly Ignacio Escalona, who's running this seminar. These are links if you're interested in contacting us in our neurosurgical department. Contact me personally if you'd like, by email or on Twitter. Today, the panelists will be Mike McDermott, good friend of mine for a couple of decades, who's moved from UCSF recently, joined here the Miami Neuroscience Institute here in town in the Baptist Health System. He's a chief medical executive. Of course, Mike is nationally and internationally renowned for his skull-based work. Fred Barker, wonderful friend of mine as well, where we've been on many roads together, particularly through the AANS and the scientific program committee. Fred is professor of neurosurgery at MGH in Harvard, and of course, a world authority on many things, but particularly skull-based, particularly acoustic neuroma, and he's going to address complications in that field today. Great pleasure to have my own colleague from here, from the University of Miami, Christine Dinh, who's assistant professor of otolaryngology. She is a neuro-otologist, one of the few neuro-otologists we have here. Christine is doing fantastic work, not only clinically, but particularly she's doing really avant-garde research in acoustic neuroma, basic science research. She's been awarded from NASBS an award for the fantastic work she's doing, and it's a pleasure to have her join us today. Kais Almefty, a great pleasure from the BNI. Of course, he comes from the dynasty I'm going to call it the family dynasty now, Almefty, between Sam, his dad, and also his younger brother who is at Temple. And Kaith will talk to us about hodgepodge of complications. And last but not least, Ashok Asthagiri, if he can get himself freed up from the operating room, as he's associate professor at UVA. Also, he will discuss a variety of skull base surgical complications. But since Mike McDermott is delayed, I'm going to ask Fred Barker to share his screen, unmute his microphone, and start the presentation. Fred, it's all yours.
Thanks, Jacques. I'm going to talk about complications in posterior fossa surgery today, particularly acoustic neuroma surgery, but and focusing more on things that really don't happen that often. So I reviewed my series for this purpose and picked out some things that it could take a while in normal practice before they happen to you. And if you know what I did about them ahead of time before they happen to you, maybe they'll help you to avoid them in the future. So basically 4 problems that hardly ever happen and some suggestions that you have to do on every case in order to avoid them in posterior fossa tumor surgery. And just to talk about the more common things that do always happen, infections, we use vancomycin and gentamicin for 24 hours around the time of surgery with vancomycin powder in the incision afterward. If there's a shunt, we add intrathecal vancomycin and gentamicin to that. Facial nerve dissection we do with stimulation, monopolar stimulation, and I stop when the EMG gets down to half the amplitude that it is when we start. Because we do most of our cases suboccipitally, we can find the nerve at the brainstem and stimulate it before doing any dissection along the facial nerve, which I think is very helpful. But now let's go on to some of the more uncommon things. So here's the case that we did yesterday. And this is an extract from my office note. You can see that's a pretty routine case, but my office note mentions that the cerebellar tonsils are okay, meaning above the foramen magnum, and the sigmoids are larger on the left than the right. So this is a routine everyday case. We didn't have any problems during this case. What is this doing in my first office note? Well, I try to teach the residents that you have to look at these 2 things on every single case, every single posterior fossa craniotomy, and I'll show you the reasons. You need to record for yourself so you can review it right before the surgery, the anatomy of the transverse and sigmoid sinus on both sides and the position of the cerebellar tonsils. Here's a case where I didn't do such a review. So this is about 15 years ago, microvascular decompression for hemifacial spasm. And the arrows show you that the transverse and sigmoid sinuses are congenitally absent on the side opposite where the surgery was going to be. Surgery was uneventful. Unknown to me, the resident had a little bit of bleeding from the mastoid emissary vein, which was controlled with bone wax. And about 3 days postoperatively, the patient comes back to the emergency room, and it turns out that the sigmoid sinus is full of bone wax, and the sigmoid sinus, and of course the transverse sinus as well, are thrombosed on that side. And of course, he doesn't have one on the other side. So this is a non-enhanced MRI. Everything you see here is thrombosis in the transverse sinus, and the superior sagittal sinus is thrombosed all the way up to the vertex. So the patient had a bad headache. I asked the stroke neurologist what was going to happen. They said the patient was going to die and that we needed to anticoagulate immediately. I don't like to anticoagulate for a full week after surgery, and this ended up, the headache ended up resolving. She never developed hydrocephalus. She must have had collateral venous drainage from somewhere else. But if we had known about the absence of the sigmoid and transverse on the other side, we certainly would have been more careful with this. There's a paper by Chandra Sen, who presented this at Grand Rounds at Mass General, showing that about 1/3 of the time after a suboccipital or a translab craniotomy, the sigmoid thromboses off. And I think that's probably a reasonable estimate. I think it's almost never symptomatic. It's almost always discovered by accident. I have seen a case in which the vein of Lebet was occluded, causing aphasia on the dominant side. I have never seen a pulmonary embolus from a thrombosed sinus. And I refused to anticoagulate until a week post-op. And in fact, I discourage any attempt to diagnose it before that time, because I'm not going to do anything about it, and it causes a lot of anxiety in the ICU physicians. If it's discovered more than 6 weeks post-op, I think it's endothelialized and there's no point in treating it. Between 1 and 6 weeks, I'm okay with anticoagulating, although I don't encourage it. And the second thing to look at on the sigmoid is whether or not the jugular bulb is high riding. This is a woman with an incidental finding of a small acoustic on this side. She wanted to undergo IV fertilization. And so wanted the tumor removed. My ENT colleague drilled into the jugular bulb, a small entry, didn't occlude the bulb. And we had subarachnoid hemorrhage basically all the way into the inner hemispheric fissure. It took about a week with an EVD and vasospasm treatment to get her through this. And then 6 months later, we came back and finished the operation. And the point that I wanted to make here is not, don't make a mistake, but if you think you're going to stop the operation, it's really helpful not to have dissected the facial nerve at all. So if you're considering stopping an acoustic neuroma operation, stop before you've started to take the tumor off of the facial nerve from either end. And when you come back the second time, all you have left is the facial nerve dissection. It makes the second stage very smooth and easy. And that's what we did in this case, completed a gross total resection. The second thing I said to always check is where are the cerebellar tonsils on the sagittal MRI? And I think it's very uncommon for the tonsils to be below the foramen magnum because of a mass lesion in the posterior fossa. The mass has got to be really pretty large, probably around the 4 centimeter acoustic, before you can legitimately blame tonsils below the foramen magnum on the mass itself, which means that if you're taking out a smaller mass, you're not going to relieve that Chiari. You're going to have an immediate post-op patient with cerebellar swelling potentially, with all the other problems that can come along, and you haven't done anything to make that situation any less tight in the posterior fossa. You should notice that the only death in Dr. Janetta's hemifacial spasm series was in a patient with Chiari who went into respiratory arrest in the PACU and could never be resuscitated, despite an emergency decompression, suboccipital craniectomy, and C1 laminectomy. Here's a case like that. This is not my own case, but the case of a colleague, 31-year-old with a 3 centimeter acoustic, and it was not noted preoperatively that her tonsils are all the way down to C1. Here you see no cisterns, no basal cisterns. When they opened up here with a decent sized craniectomy, they couldn't even see the tumor. A cerebellar resection was necessary to get to the tumor. A pretty generous portion of the tumor was removed, and then the operation just simply got too hard to continue, and they closed up. The patty count was incorrect, so this CT scan was obtained before the operation was even finished, and you see hydrocephalus developing already. And about 36 hours after this patient was extubated, she ended up getting a shunt. So you don't want that to happen without warning. Here you see the post-op scan. This is after most of the tumor has been removed. You see the shunt and you see the tonsils down to C1. So it was not the mass that was causing this. This is a Chiari situation. And a Chiari happens in about 1% of patients. So you have to look in the other 99 who don't have it in order to know about this. What can you do if you know about it ahead of time? Here's a 49-year-old man, small acoustic. I thought this was a perfect case to do the day before Thanksgiving in 2011. Didn't anticipate any problems at all. Tight cisterns, a little bit below the foramen magnum here. I thought we'd be extra careful, and so we did an EVD at the start of the operation. We ended up getting the tumor out without any difficulty. You see the size of the craniectomy we did here. We did an enormous craniectomy, a big patchless dural graft, and put mesh in here rather than replacing the bone flap. That gives you an extra centimeter of space here that you see filled up with air. And 36 hours after surgery, this guy had no lateral gaze in either direction and was starting to look really bad. We elevated his sodium up to 160, and between breakfast and lunchtime, he suddenly felt fine. He told the nurses that he had had a feeling that something horrible and terrible was about to happen to him, and that feeling had gone away, and now he was eating lunch. So it can get better very quickly. And this was the case that taught me that you can put the sodium up to 160 or 165 in a healthy young patient and get a lot of cerebellar contraction out of that to get you through a tight space. So what do I do about it? When I see it ahead of time, I use an EVD. I do a large craniectomy, patchless dural graft, mesh rather than replacing the bone flap to give extra room. If you do need to resect the cerebellum, go for the inferior portion of the hemisphere, not the superior portion, down by the tonsil. This normally recovers fully, even on the dominant side, even on the right side. The right cerebellum is the dominant cerebellum. And I ask for a central line to be placed before we start the operation, because these are patients that you don't want put in Trendelenburg postoperatively. So have all this in place ahead of time, be ready, and if the course gets rough, you can pull out all the stops and get people through some very tight jams. The third problem, the Petrosal vein. Almost every case, you see the Petrosal vein close to the internal auditory canal. Almost every resident asks me, well, can you take the Petrosal vein? I've seen Dr. So-and-so take the Petrosal vein. Dr. Ogeman used to take the Petrosal vein on just about every acoustic. And he told me that he had had one very bad problem in 1,000 cases. And I saw that problem. That problem ended up with the patient leaving the hospital in a debilitated condition. So I decided to try to do my own surgery without taking it. I've had two personal cases where Petrosal vein sacrifice, whether purposeful or inadvertent, was followed by a serious venous infarction. Here's the normal anatomy. This is from Roton's publication in Journal of Neurosurgery. This is your Petrosal vein, sometimes called Dandy's vein or the superior Petrosal vein. Here's the IAC here. It runs from the brainstem to the superior Petrosal sinus. Here it is on an MRI, and on the opposite side, you see this, what I call a Petrosal Meningioma, and you see how the conflict can arise. This is a young woman, 45 years old, who presented with left facial numbness, and this is the Petrosal vein here. You see it here taking off and going into the superior Petrosal sinus. This vein actually ran through the tumor, and at the time of surgery, dissecting the tumor away from around this vein, it appeared to me that the vein was atretic and had no blood flow through it. So we sacrificed it in the interest of getting a total resection of the meningioma. She looked fine post-op. About a day after surgery, she fell over while walking to the bathroom, and this CT scan was done. And you see this, in what was called an infarction. The MRI did not show any DWI bright area here. This was sufficient to cause hydrocephalus, not bad enough to need a EVD. And her exam was very concerning. She first lost left lateral gaze, then developed a very bad left ataxia, really a violent ataxia. And finally, when her left gaze started to return, almost a week after surgery, she was left with a left abducens palsy. And it wasn't for 2 weeks after surgery that she was able to walk. And she came back to the office 6 weeks after surgery, completely normal exam, ready to go back to work, and obviously no infarction on the scan. So I don't think there's any explanation for this except that we took the Petrosal vein, because this is exactly where the Petrosal vein drains. Here's a second case. This is, again, about 10 years ago. The slight blurriness here is because these are photographed off of film. This is a large epidermoid in the left cerebellopontine angle. This is a vein draining from the cerebellum, stretched over the top of the epidermoid into the superior Petrosal sinus. And while removing the epidermoid, this vein became more and more redundant, hanging down into the operative cavity, and eventually was pulled partially out of the superior Petrosal sinus. And I decided it was okay to take the vein. And here we are 3 days post-op with a large venous infarction of the cerebellum. Again, it got better, but a very rough post-operative period. So I've decided that basically it is never okay to take the Petrosal vein, because you never really know when it's not going to be okay. Cerebellar hematoma and swelling. This is really a dreaded complication. Ogeman would routinely resect cerebellum as the first move in taking out any acoustic neuroma larger than 3 centimeters, and he always used retractors from the beginning of the intradural surgery. And during that era, about twice a year, about 2% of cases went back to the OR like clockwork for hematoma or swelling. I decided to get away from those things and try not to use retractors, try not to resect any veins. So I'll show you a case where those things did not work. This is a 14-year-old who was referred to me from Boston Children's Hospital. He had had total body irradiation 10 years previously for leukemia as an infant and had chronic thrombocytopenia, ran about an 80 to 100,000 platelet count, developed papilledema at age 4, and an MRI was done, which in retrospect showed a tiny acoustic neuroma on one side, probably because of his radiation exposure. At age 14, he presented again. He had short stature. He's the size of a normal 10-year-old boy and now has a 5-centimeter acoustic neuroma on this side with no hearing, hydrocephalus. So for the first time in my career, I decided it would be better to try to stage this, to do a debulking procedure, and then come back at a second stage to do the facial nerve work. And we did so. We brought his platelets up to about 120,000 with a platelet transfusion, removed the tumor, no retractors. This is the tumor remnant here, extending from the brainstem up to the IAC. We had an EVD for the case, and he awoke with full facial function and in fact, a normal exam. And I thought we were in great shape. And then 36 hours post-op, he became obtunded. The vocal cord became paralyzed. His face became paralyzed. He lacked lateral gaze to this side, and he had this hemorrhage in the cerebropontine angle. This hemorrhage is in the brainstem. This is a hemorrhage in the subgaleal space. This is a hemorrhage in the subgaleal space where the EVD was placed. So he has a generalized coagulopathy. We took him down emergently to the operating room, evacuated the hemorrhage in the cerebellopontine angle, and got him through it. His vocal cord got better. He never had any facial nerve recovery. So what have I done over the years to avoid postoperative hemorrhage? Dr. Janetta taught us that this comes from retraction of the cerebellum. And in reviewing my own case, about the first quarter of my series, we had about a 1.5% return to the operating room. After I got rid of the retractors, we went down to 0.5%. And I think avoiding resecting any cerebellar draining veins is also helpful. I teach the residents this. This is something that most of them don't believe until they've seen it. You say, what do you do when the dura is full? This is a 260-pound man. The dura is tight. You're going to open here. You're going to have to pull the cerebellum up to get down to the basal cisterns to get the EVD, to get the CSF out. And they say, well, I would ask for some mannitol. I would ask for end-tidal CO2. None of those things really do anything, at least not quickly. But watch what happens if you put the patient in 20 degrees of reverse Trendelenburg. You see the dura is now actually concave. So keep the patient flat, do your exposure, reverse Trendelenburg, and you no longer need to retract the cerebellum. This young man, by 9 months post-op, had no facial nerve recovery, and so he was taken by our oculoplastic service down. He had an anastomosis of his masseteric motor nerve to the facial nerve, as well as a hypoglossal to facial. And here is his post-operative result from that. So this is a complete facial palsy. You see the eyelid weight, and you see just about 3 months post-op, an excellent smile from this facial reanimation procedure. So I think it's important to have good colleagues who can do good facial reanimation work if you're going to deal with difficult acoustic neuromas. Unfortunately, his tumor remnant that we had intentionally left grew during the COVID epidemic. And when we brought him back to resect this, this is the other thing. If there's been a reanimation of the face using the masseteric branch, you can monitor the motor 5 intraoperatively, recording the EMG in the face and stimulating 5 at the brainstem, and preserve this. And his biting smile went out for about a day post-op and then fully recovered within about 3 days post-op. So those are my advice about avoiding rare complications in acoustic neuroma surgery. And Jacques, I'm happy to take any questions, and thanks for the opportunity to speak.
Fantastic. This is very, very useful. I'm sure the audience appreciates all these pearls. You know, since you might not be with us after 6 p.m., you might leave us. I haven't seen any questions from the audience yet, but I'll ask you. I routinely, Fred, I teach my resident when we open the dura on an acoustic or whatever, posterior fossa, I open it under the microscope and the lower end of it looking towards cisterna magna. I don't take the craniotomy down foramen magnum, but I get that first step, getting that CSF early on. Then when the cerebellum is down, I fully open the dura. How do you do it that way? Do you do it any different way?
You know, if you put the patient in reverse Trendelenburg, you can just you can do the full dural opening. I know that practice of opening a flap down at the bottom and then peeking in and really retracting as little as you can, getting to the basal cisterns. But if try it and see if you
I put my patients reverse C, but sometimes they're pretty full. So I regretted it.
I often don't find that's needed. I'll tell you what I do now, and I since you're looking at the accessory nerve when you've done that, I ask for the stimulator and stimulate the accessory nerve with 1.0 and confirm both that the patient is not paralyzed from anesthesia, which I've had happen, and also that your equipment is working.
Right. Any of the Christine or Kais, any of you has perhaps a question to Fred? Otherwise, we'll move on to Christine for the talk. You're muted. Okay.
I guess while we're doing the question and answer, I'm just going to go ahead and set up my screen.
Please, yes. And by the way, my apologies. Christine, of course, is an associate professor. I misspoke earlier. But since I remember her as a resident, I always think of you as very young, and you are, even though not in professorial stage. Thanks.
Oh, thank you. I guess if there's no questions, I can start.
Please go ahead, Christine.
Okay, so well, thank you.
Yeah. I'm sorry, 1 second. I see one. Okay, yeah, go ahead. That was just a remark from the audience. Somebody, Dr. Bennett is congratulating you, Fred, for the presentation.
Thank you.
Thank you. Go ahead, Christine.
Thank you, Dr. Marcos. So in my talk today, I will be discussing ways to prevent some common complications in temporal bone surgery, particularly as it relates to transmastoid approaches. I'll be giving some tips and tricks that I guess I've learned over the years, and then highlighting important temporal bone structures through anatomical dissections. I guess it would be kind of difficult to kind of have an understanding of some of the anatomy of the temporal bone without going through it, especially for those that maybe are not neurotologists. So I'm just going to take a couple of minutes and just go through some of the layers of the temporal bone and structures that we try to identify and try to preserve. So this is an anatomical dissection on a cadaver. We've transected the ear canal, and so you see the EAC here. In front of it is the parotid gland. Behind it is the mastoid bone, and above that is the temporalis muscle. If we do a parotidectomy, we can see the facial nerve and all the 5 branches that move the face, and if we trace it proximally, we'll get it, the facial nerve will exit the mastoid bone at the stylomastoid foramen. If we do a conventional mastoidectomy, there's important structures that we try not to miss, which include the tegmen, which protects the temporal lobe, the sigmoid sinus. And as we drill deeper, we try to identify important landmarks such as the horizontal semicircular canal, and from there the incus. If we drill below the incus, we can enter into the middle ear and find the cochlea, the stapes. Oftentimes they're not. We're preserving the chorda tympani and the facial nerve. And however, if we need to access structures that are much deeper for pathology reasons, we can remove the ear canal by drilling troughs above and below the ear canal. transecting the tensor tympani, removing the incus, removing the temporal bone itself, as well as the mastoid tip to be able to get to important structures that are deeper in the ear, which include the Eustachian tube here. And at which point you can see all the 3 semicircular canals that are important for balance, and preventing dizziness. And if you follow the sigmoid sinus down, you can see the jugular bowl before it enters into the neck. If we do drill a lapenthectomy and remove the cochlea, you can see the 3-dimensional structure of the 3-dimensional pathway of the facial nerve in the temporal bone, from the IAC, the labyrinthine segment, the geniculate ganglion, the tympanic segment, as well as the mastoid segment right above the jugular bulb, and the petrous carotid artery. If we remove the facial nerve, we get even deeper, and at which point we're at the jugular foramen, and we see the lower cranial nerves 9, 12, 10, and 11, as well as the internal carotid artery becoming the petrous carotid artery. And if we drill behind that, that will be the petrous apex. So it's a very multi-dimensional structure, and having a good command of the anatomy will prevent you from having many complications. We talk about complications, and the most common but probably the least reported are the soft tissue failures. I just wanted to spend a couple of minutes on that. And this is one of my patients that I did with Dr. Marcos. It was a retrosigmoid craniotomy for vestibular schwannoma. And one of the residents elevated an anteriorly based skin flap. And when they raised it, they got too close to the dermis, right about here, where the bruising is. And after a couple days after the surgery was complete, the wound broke down. There was a CSF fistula through a 1 centimeter defect that we had to repair with the temporal parietal fascia flap underlay enclosure. So one of the lessons that I learned, and I think this applies to many other of my cases, to keep the skin flap as thick as possible. And this will prevent complications such as CSF leak and meningitis. I often do cases with the head and neck team as well as the neurosurgical team. And one of the common ones that we do is a transjugular approach for glomus jugulare. Some of our patients have really big mastoids and really big defects after we resect the tumors. When I was in fellowship, we used to close these with just like an abdominal fat graft, and our risk of pseudomeningoceles and CSF leak were fairly high. And since becoming a faculty member, we were using the temporal parietal fascia flap much more, which has reduced my CSF leak rate and pseudomeningocele rate significantly. I rarely see one nowadays, but by removing the temporal parietal fascia flap, I'm also devascularizing the skin edges by diverting the superior temporal artery, which is part of the flap. And I've noticed that in my older women with very thin scalps that I tended to have these dehiscences that require some dressing changes and recovery in about 1 or 2 months. And one of the lessons that I learned after doing this a few times is avoid the TP flap in older women with thin skin, because we're lucky that we didn't get CSF leak. So the TP flap did what it was supposed to do, but there was always a risk of wound infection that could progress to meningitis. So avoid a TP flap in older women with thin skin. I'm sure we've all had our complications related to CSF leak and pseudomeningoceles, but it's particularly annoying when they happen in a temporal bone in a patient that still has hearing, because oftentimes or not, we'll have to re-explore and repair. So the best time to stop a CSF leak from happening is to prevent it before it happens. This is a case I actually did with Dr. Marcos early on. And actually, I was a fellow when this happened. Retrosigmoid craniotomy for a vestibular schwannoma, uneventful. And the patient went home with no issues. And a few days later started leaking CSF from his ear, and nobody knew why, because the tympanic membrane was completely intact and we had no idea where the fluid was coming from. So it took a while to kind of figure out what to do. And we eventually brought him back to the operating room and took a good look. when he was asleep, and we saw a hole in the ear canal, and well, this is a retrosig. Why would we have a hole in the ear canal? So we ended up dissecting it from behind. This is the mastoid bone here, and this is the ear canal. We see a hole. And so lesson learned, don't put a fish hook through the ear canal skin. These are very hard to repair because the skin of the ear canal is very thin, doesn't really have very good subcutaneous tissue. So any sutures that you put in it will easily tear. And plus it's right at the bone here, so it's really hard to put a suture in. So what we ended up doing is we ended up doing a mini temporal parietal fascia flap to kind of cover the hole, and we put it there. We sutured it in place to kind of occlude the hole and prevent CSF from pooling in that area. After that, we put maybe one very loose stitch in the ear canal because the skin was very friable, and we packed the ear canal with Xeroform. That significantly reduced the CSF otorrhea, and with a lumbar drain for a couple of days, he resolved. So another lesson learned, don't put a fish hook through the ear canal. Every now and then I'll remind the neurosurgeons and even my own residents. Because the patient had hearing, we couldn't go back and just plug the Eustachian tube or like close off the ear canal. So we really have to repair the CSF leak in the hole. So we've all seen pseudomeningoceles, and I used to see them more often, mostly in our obese population. But this is a retrosigmoid approach for vestibular schwannoma, and she developed a delayed pseudomeningocele. And it really required 1 month of a pressure dressing to really get this to go away. And over the years, as I guess we operate on other vestibular schwannoma patients that also have a high BMI, I always think back on this patient, and some things that I've done is considered a lumbar drain. Now puts tacking sutures pretty much consistently to kind of obliterate the dead space, basically putting interrupted sutures between the deep and the superficial tissues, and kind of in a strategic way, so that way no CSF can accumulate between the tissues. And one of my neurosurgical colleagues has been using bone cement to kind of fill in the space between the bone flap and the actual mastoid bone, and that I think has helped a lot. I don't think I've seen a pseudomeningocele for a long time, except for maybe one of my patients that has an ABI and intracranial hypertension. So when I was a fellow, I was surprised at our CSF leak rate after translab. I think we closed it kind of traditionally, like textbooks describe. We'll pack the antrum, the middle ear, the Eustachian tube, and just put fat through the dura after we try to reapproximate it. I'm going to show a little video, just kind of what we generally would do for a translabyrinthine closure. I'd put bone wax on some of the air cells. Then I'll harvest some fascia from the temporalis fascia. And then I'll look into the middle ear through the antrum, and I'll pack the Eustachian tube, actually literally put the gimmick instrument into the middle ear all the way to the Eustachian tube, and just plug the Eustachian tube as much as possible, and also fill up the middle ear cavity. I usually do that with layers of fascia and Surgi-cel, at which point after I've packed, then we generally take strips of abdominal fat, and we'll put it into the defect, and then after that layer some more fat. But I think I've gotten smarter over the years, so we've made some tweaks to this technique, and to reduce our CSF leak rate, and I don't think I've seen one for a long time, so I think it's helping. This patient actually had CSF rhinorrhea. So because the patient didn't have hearing, we could close it in different ways. We can go back and repack, but when a patient doesn't have hearing, we can kind of use all the tools in our armamentarium and consult our anterior skull-based rhinologist for eustachian tube obliteration. And so this is a view of the endoscopic view of the ear canal. You can see the left tympanic membrane with some CSF behind. It's a little bit green from the fluorescein. And this is a repair, endoscopic repair, eustachian tube obliteration. I'm just going to go through quickly some of the steps. But here you see the left eustachian tube's a little bit swollen from the injection. But our rhinologist will microdebride the mucosa in the center of the eustachian tube orifice until they find the lumen, which is right here of the cartilaginous eustachian tube, at which point they'll pull in some alloderm and they'll invert the mucosa and pack the lumen with some alloderm. And then they'll reapproximate the posterior and the anterior, I guess, tori of the eustachian tube to prevent CSF leak. So this is them struggling with the putting the stitch in, and they'll lay gel foam on top and then a Marcel, and that's how this CSF rhinorrhea was repaired. It's definitely something good to have in your armamentarium. Since then, I've changed just a little bit what I've done. Not only do I pack the eustachian tube in the middle ear space, but now I place a layer of DuraGen over the dural defect, one that covers the antrum, as well as the entirety of the dural defect. And then I put strips of abdominal fat above that, just to kind of put some tension between that tissue and the dura, which I've been very lucky to not have a CSF leak for a long time. And I'm just going to re-emphasize the importance of attacking suture, because I feel like that will prevent pseudomeningocele, especially in translab patients. So it's kind of hard to talk about CSF leak in translab without also talking about retroseg. So I just included a small video of what I do now for retroseg. I haven't had a CSF leak, thank goodness, recently from a retroseg. But before, I used to pack individual air cells, but now I just layer a full, I put a full layer of bone wax over the superior and inferior troughs, as well as laterally, to cover basically the entire area that I drilled. I then layer some SURGEry-cell, a DuraGen, and some more SURGEry-cell. And I think my CSF leak rate has been extremely low, and I wanted to share that technique. This is the DuraGen going in, and after that is the SURGEry-cell. So hearing loss, there are a few scenarios in which hearing loss is a complication of transmastoid surgeries. As we surgeons, we choose the approach often based on hearing. But one particular scenario, when a patient requires a combined Petrosso approach, and we're actually trying to preserve hearing while drilling near important critical structures. We actually worry about what the hearing is. And so in patients with large Petroclival Meningiomas, those that I guess cross over the posterior cranial fossa, as well as has a large component in the middle cranial fossa, it's nice to be able to remove this in at least either 1 or 2 stages, but through one approach. And generally we'll do this through a combined Petrosso approach. If the patient has hearing, a retrolabyrinthine approach with the middle cranial fossa. If we need more space, maybe we'll do a partial lapenthectomy. And that's when we're kind of worried about hearing loss. So the difference between the two is in a retrolabyrinthine approach with the middle cranial fossa, we preserve the superior and the posterior semicircular canal. So if you're trying to access the clivus and remove the Petroclival Meningioma, you might not have the best exposure, especially if the patient has unfavorable anatomy. But if you're able to plug the 2 ends of the superior and the posterior semicircular canals, you can drill through them, and while preserving the endolymphatic sac, offer another centimeter of exposure, which could make or break having a gross total resection and reducing injury. So I wanted to show just a short video of a partial lapenthectomy for combined Petrosso approach, and it's a nice approach to have and know how to do. However, I feel like a retrolabyrinthine approach has less risk of hearing loss and provides a fairly decent exposure if you combine that with the Petrus apicitis. You can see here, I'm just going to rewind just a little bit. We blue lined the superior and posterior semicircular canals here. We're now plugging the ampullated end of the posterior semicircular canal with bone wax. We're now occluding the common crus and then the ampullated end of the superior semicircular canal. Sometimes people do that with bone wax, sometimes people do that with fascia, but after you drill through the semicircular canals, you get a very good view of this area and better access to the clivus. With a 15% risk of hearing loss associated with that surgery. So a retrolabyrinthine approach can provide fairly good coverage too, and if you combine that with like anterior petrosectomy, I think it provides a lot of good exposure without risking hearing as much. So here you see us drilling around the semicircular canals. That's the superior. This is the posterior. This is the lateral. Then we'll identify the endolymphatic sac and decompress the jugular bulb to be able to provide maximum exposure. And you can see the sigmoid sinus and the endolymphatic sac is exposed. So now we're doing the middle cranial fossa approach and making cuts in the posterior and middle cranial fossa dura. And we're connecting the two approaches by, I guess, by sacrificing the superior petrosal sinus, after which we have cut the tentorium and identify the fourth cranial nerve, which is what you're probably going to see very soon. There it is right here. And start dissecting your meningioma. And I think what's great about this surgery is that we haven't gone through any vital inner ear structures yet. This is us dissecting the lower cranial nerves. This is decompression of the sigmoid. And at the end of the surgery, when we remove all of the Petroclival Meningioma, we get a very good view of the brainstem here, as well as 7th and 8th nerve, which is here. And you can see a gross total meningioma resection, even though we didn't have to do a partial lapenthectomy. We bone wax the air cells, we harvest some fascia, and then we cover the antrum and then pack with fat. And I think this is a great exposure that increases the rate of hearing preservation in our patients. So facial paralysis, I am done. I think I have 1 or 2 more cases I wanted to present, but facial paralysis is a complication that unfortunately we deal with more often than we like for various pathologies. And the worst complication is when the patient develops facial nerve paralysis when there's no significant involvement of the facial nerve by tumor. So one of the probably stressful surgeries for me is the glomus jugulare, the transjugular approach, because oftentimes we need to transpose the facial nerve anteriorly, and that can risk facial nerve injury, as well as, have other risks such as carotid and jugular bulb injury, but oftentimes or not, the facial nerve is not involved, and having a facial nerve paralysis that doesn't recover completely with those types of surgeries can be devastating for the patient. So this is a patient of mine that has a glomus jugulare, and we did a trans jugular approach. This is a tumor that has been embolized, and part of it is in the middle ear space. The ear canal has kind of been removed already. And you're going to see us doing a very quick dissection of the middle ear tumor and drilling the facial nerve here, which is the mastoid segment. We then decompressed it, and we now want to trace it out to the stylomastoid foramen here, but to transpose it and give more space to drill the jugular foramen, oftentimes or not, we have to move the facial nerve and decompress a little bit higher. So that's what we're going to do. We're going to decompress a little bit higher, closer to the tympanic segment, which is where you see here. And now we're decompressing the facial nerve and transposing the facial nerve from the geniculate ganglion scan all the way to the stylomastoid foramen and to be able to move it out of the way. We still have to drill this area. And so, this facial nerve is hanging in the breeze. And, I've seen some bad horse, terrible videos of the facial nerve getting caught in the drill. So generally what I'll do is I'll put a little bit of bone wax just to kind of push it out of the way anteriorly and drill the jugular foramen at that point. This is, I guess, I think probably Dr. Morcos doing the surgery where he'll amputate the internal jugular vein, dissect it up into the jugular foramen, at which point he will pack the proximal end of the sigmoid sinus with some Surgicel. That's what you see him doing there. And we've removed the tumor, dissected intracranially. And the facial nerve is intact, but the patient had a complete facial nerve paralysis, and it did recover to Hausbachmann 3 with a lot of synkinesis. But this is kind of Hausbachmann 3 with synkinesis is really not a good function overall, especially for a young patient that was 18 years old. So nowadays, what I do is I limit my facial nerve transposition to only include the mastoid segment of the facial nerve. I don't include the second genu. I don't include the tympanic. I don't go all the way up to the geniculate, because as you can decompress and you transpose the facial nerve there, you can lose the blood supply to that facial nerve. And I've actually gotten really good exposures with really good facial nerve outcomes. People will have a post-op 2 to 3 and have recovered to 1 or 2. So I've been very happy with sticking to this lesson learned, limit the facial nerve transposition to the mastoid segment of the facial nerve. And the last thing I wanted to talk about is the carotid artery. I think, thankfully, unfortunate, I have not and wish never to be in a situation that I have to deal with a carotid injury. And I think that's perhaps because we analyze CAT scans and MRIs, we map our surgical approaches, we present them at our skull-based conferences. And when a malignant tumor involves the carotid, perhaps maybe we choose to operate we may choose not to operate, or we will choose to sacrifice and or leave benign tumor adherent to the petrous carotid artery just to prevent issues. And I just want to highlight one, just like some anatomy, because the petrous apex is part of the temporal bone. It is the most difficult part for us to get through. And one of the most common benign lesions is a cholesterol granuloma. And sometimes it's very difficult to get to this area without hitting the carotid, hitting the jugular bulb, hitting the facial nerve, hitting the cochlea, the inner ear, the choroid tympani, and causing a whole bunch of issues. So we'll map it out to see if there's a passageway that we can get to without injuring any important structures. And this is us just doing a traditional mastoidectomy and facial research recess approach. And we're trying to by mapping it out, we can determine whether we can go through the superior semicircular canal crura, go from behind the supralabyrinthine air cell tract, the infralabyrinthine air cell tracts. All of this, if you really know your anatomy and you drill it right, you can avoid injury. And this is one of our patients with an infralabyrinthine approach for the petrous apex cholesterol granuloma. And you can see we missed the facial nerve.
Sorry, maybe 1 minute, just if you could. In 1 minute or so, 1 to 2 minutes. Please.
Yes, the posterior semicircular canal is here and we missed it. And this is going through the ear canal and drilling infracochlear right below the cochlea. So, and an endoscopic view looking into the cholesterol granuloma and seeing the pulsating carotid artery. This is my last slide. So it's important to do that. So wanted to leave with something positive. Thank you. I wanted to thank the directors and Dr. Morcos for inviting me to give this lecture. Thank you. That's the end.
Fantastic. Fantastic review of the temporal bone and all the aspects that neuro-otologists, neurosurgeons have to deal with. I think it's best if we actually answer questions as we go. Question for you, one question, Christine, from the audience. How did you manage the TP breakdown in the 65-year-old patient? I think they're referring to one of the early cases in your talk. You remember?
Yes, yeah. So we ended up doing that a wet to dry. We originally start with something that's antibacterial, which is Xeroform, and she'll change that dressing twice a day, and that will kind of granulate the tissue in. And after that, we kind of take the Xeroform out, and I had another patient in which we just did saline, wet to dry with saline. But once the tissue granulates in, then you remove the dressings and you just put ointment on it, and the epithelium grows on top of that. It takes a little time depending on how deep the defect is. It can range from 2 weeks to maybe a month or 6 weeks before everything is completely healed. But that's generally how I will treat those if there's no CSF leak.
Great. Thank you so much. Thanks, Christine.
You're welcome.
Let me invite Mike McDermott, who eventually was able to escape from the OR and join us. Mike, I did your introduction earlier, so I'm not going to do it again. I said what a wonderful guy you are. But you can unmute your microphone if you want us to hear anything, and share your screen if you're ready. Mike, I think Mike is going to talk about reoperative surgery on meningiomas of the skull.
You see my slide?
Perfect. Thank you. Yes.
So yeah, my talk is going to be brief, and it's going to be about the reality of surgical results. Christine doesn't have many complications, but apparently I do. And this was a talk that was presented at the North American Skull Base Society meeting back in 2016. And many things aren't really that new. So about 1/3 of open operations are related to skull-based meningiomas. Recurrence rates vary. Even though it's a benign tumor, surgery is not the only answer. And there are many series that talk about primary operations, but few that talk about reoperations. And the old adage about operate, 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 I thought was not the right message, because as many of us who are more senior know, that as you do that, the tissues really don't tolerate it. And if you can't get the tumor out the first time, the likelihood you're getting it out the second time is low, and it's lower on the third operation and lower on the fourth, and the complication rate seems to rise. So it's really not about operating on a scan, whether it's a chronic subdural or a skull-based meningioma. It's really about the clinical outcome for the patient. Is there a relationship between the patient's symptoms and the imaged tumor? And if you decide that the patient needs reoperation, the complication rate is not the 3 to 5% the resident quotes the patient in the pre-op area. That's not actually where informed consent takes place. It should be taking place with the responsible surgeon, and that information should be, I think, derived from your own institution, rather than taking Jacques and Christine's results and saying that yours are the same, which is probably unlikely. So we decided to look at this. I started at UCSF in 1992, worked there until February this year. All these patients weren't mine. Fred knows how many. Fred Barker was on the call, did a paper once on the frequency of meningioma operations in North American sites, and we did a lot. And the inclusion criteria were reoperation for recurrent tumor and primary skull-based location. And we went through where we headed, the electronic medical record. Obviously, that didn't start until 1997, along with digital imaging. So there's some period of time where we had to rely on paper charts that were in storage, which we looked at. So here are the results. 78 patients, 100 reoperations. Demographics you can read there. Patients were thankfully fairly young, but you can see the upper range was 88 years old. Median follow-up after diagnosis appropriately long in this case, 8.5 years, not 8.5 months. And you can read for yourself the initial presenting symptoms prior to reoperation, typical for what you'd expect. High incidence of cranial neuropathy, predisposition for two, probably because of the more the tumors being in the anterior middle fossa. Data about grade, which I don't really think is important, other than the fact that the higher the grade or atypical meningiomas will frequently have associated surrounding edema. And if you have edema in the midbrain pons or medulla, you can forget about getting the whole tumor out unless you want a hemiplegic patient. So I learned that when I saw that feature on the T2 weighted images, I told the patient, I can't get this whole tumor out. I did it once in a 24-year-old, and I got the tumor out, but he was plegic and then ended up with a bad spastic hemiparesis and a useless arm. So I never did that again. Location of tumors, as you can see, anterior, middle, posterior fossa, largest tumor dimensions. So thankfully we weren't operating on what we would call in the colloquial language, little boo-boos. These were tumors predominantly that were more than 3 centimeters. So they warranted reoperation. And frequently at that size, it's a contraindication to doing some other adjuvant form of treatment like radiosurgery, although you can do fractionated treatment safely in larger tumors. And you can see there was only a few patients that had more than 3 operations, only 2. But the key thing is, as you'll see, the complication profile with the first and the second reoperation where the numbers are reasonable. So on the top, we have first, second, third operation, median age at surgery, median time since the prior surgery in years, 4.4 years on average, follow-up after the reop. And some of the patients, not a huge number, had prior treatment. So this wasn't because we did use a lot of radiosurgery at UCSF and it failed or the tumors became malignant, therefore we had to reoperate. Actually, 90% of the patients had not had other adjuvant treatment. The good news, this slide is a little bit out of order, but I switched it because it's not all doom and gloom. And if you look at the median survival outcomes after diagnosis, it's good. Median survival after first reoperation, even after second reoperation. So as long as the patient has a good clinical status, functional status, it's worthwhile. An 80-year-old who's plegic in bed with multiple cranial neuropathies or aspiration problems, we're not reoperating on that person. But here's the complication rate, 32%, 41%. These are really the figures that matter. It gets higher as you go up, as you'd expect. And 80% of the complications that occurred after the first reoperation required another operation to fix the problem. Not just a lumbar drain, go back to the OR and have another operation. Free flap, rotational flap, you name it. Here are the complications listed by type: hydrocephalus, leak, infections, hematoma, hemiparesis, cranial neuropathies, and thankfully the predominance of the complications was related to CSF. It's interesting to note that there was a recent paper, I think it was in neurosurgery, that showed that cerebrospinal fluid inhibits wound healing. So once you've got a leak, it promotes the leak. So in order to get the tissue to heal, you actually have to stop or divert the CSF somehow. So I thought that was interesting. We don't know what the molecular basis is for the inhibition of wound healing with CSF. There were other medical complications not requiring another operation, usual stuff, DVT, some minor medical things, hyponatremia. As you know, the coders, if your sodium drops below 132, you get an email that you now have another complication. So we had to include this kind of stuff, urinary tract infection counts, but nothing serious. So we looked at risk factors, univariate factors that you see up there. Tumor size greater than 3 centimeters was predicted that we were more likely to have a problem, and posterior fossa location, although not significant, was trending that way. Again, not a big surprise. So we followed this paper about complications after reoperation for skull-based meningiomas with complications after reoperation for non-skull-based meningiomas of the cranial vault. And it was interesting that the complications after the first reoperation for cranial vault was exactly the same, almost exactly the same as for cranial base. So not straightforward. The good news is the patients, if they're well and you don't hurt them, they can have good long-term survival, as I showed you. The complication rate is high. So tell the patients the truth. Don't tell them that it's 3 to 5%. Most of the problems relate to CSF leaks, and thankfully the majority of those can be fixed. If you have a small recurrence that's not symptomatic, think about other modalities rather than reoperating again in order to provide the patient with tumor control. And I think one of the things that, I mean, Jacques and Fred and I know it, is that experience makes you more humble. And on the other hand, I think in one of the recent studies that we did related to tuberculin meningiomas, I was very impressed with the quality of the results for first-time operations. So I think it's a credit to the specialty. And as Christine just showed, you have to be very meticulous with the tissues all the way in and all the way out in order to get a good result. And that's all I had to say. Thank you.
Thanks, Mike. Yeah, it's as you know very well, and I know very well, they can be so frustrating, those recurrent meningiomas, and every time you reoperate, you lose ground. But certainly your vast experience, thank you for sharing it with us. Let me see, there may be one question.
I do want to mention, I want to clarify, it's that we don't have a lot of temporal bone complications. I didn't mention any of those related to tumor, just because Dr. Marcos wanted me to focus on temporal bone, but definitely I'm not without complications too.
I'm relieved. I thought I was, after all these years, I thought I was inferior. I was worried.
Yes, I just wave the magic wand and, the tumor disappears.
I didn't have any
no, that doesn't happen.
Dr. Marcos had them all.
A question for you through John Bennett. What tactics do you employ in choosing patients for reoperation versus adjuvant therapy? You're muted, Mike.
Yeah, obviously symptoms, whether the imaged tumor recurrence is causing the patient any problems, number one. Number two, location. So if you call the middle cranial fossa skull-based meningioma, that's a lot different than a recurrent Petroclival Meningioma that's had a previous posterior petrosal approach. The surgical approach can be way different. And then size. So if it's small, I would think of other, and age, patient and tumor factors, age-related, small tumor, older patient, less likely to reoperate. Bigger tumor, younger patient, good shape, more likely to operate, to reoperate. So those kind of factors.
Mike, another question from Nicole Betty. What about using a wafer for the meningioma? I'm not sure if she's referring to Gliadel.
BCNU like Gliadel? No.
She does. Yeah. I'm not sure that's, yeah, correct. Not applicable.
Well, you can't, and you can't put it in the CSF space. That's right. Contraindication.
Okay, fantastic. I think that's all the questions we have for.
Is there a question from Fred Barker?
What's that? No, he's gone. He left us.
Okay.
Thanks, Mike.
Right.
Now I invite Kais to unmute his microphone, share his slides, and I think Kais has in store for us, I believe, a selection of different skull-based complications. And after Kais, we will see if Ashok Asthagiri has managed to finish his acoustic neuroma. He will join us. Otherwise, it will be the end of the session after Kais.
Okay, 1 second. Let me just fix my screen.
Keith, how's your dad doing?
He's doing good. Thanks for asking.
Say hello from McDermott, please.
Well, I will, yeah. Okay, am I sharing my slides?
Not yet. No, you're not sharing the screen yet. Open the PowerPoint and then go back to Zoom.
It seems that it's, yes,
there you are. Now you're good.
Okay, great.
Pursuing expertise in an early skull-based practice. You're on.
As the junior member of this panel, I think this is probably the one topic area I can have maybe equal authority with my co-speakers. With complications, neurosurgery hasn't done a very good job of defining complications. The general surgery world has. There's more than just complications in negative outcomes. There's sequela, and there's a failure to cure. And these are three distinct things where a complication is a deviation from the normal postoperative course. And you can see their list of complications here, grading on what's needed to correct that complication. So a grade 1 complication might just be a postoperative atelectasis, whereas grade 5 is death. And then sequelae, something like a inability to walk after an amputation, an expected outcome, and then other negative outcomes are a failure to cure. In neurosurgery, we haven't defined these well, although some have attempted. Where does a facial nerve palsy after acoustic removal fall in this category? Is it a sequela? Is it a complication? And that's a matter of debate. Failure to cure in skull base is very obvious, and we see it often, and it's often the balance in our case between complication and failure to cure. Here I show you my very first giant acoustic neuroma, which radiographically had a good result, but the patient had a complete facial nerve palsy. My very second giant acoustic neuroma looked like this. I would certainly say that both of these cases were failures or negative outcomes in some regard. I think that we can't talk about our failures without at least addressing success and learning. And when I think of expertise in neurosurgery, these are my two mentors, and they really have taught me about expertise, and they've taught me about this constant pursuit of improvement. It turns out that expertise is actually a very well-studied topic, and I would encourage you to look into these things. This is the source of Malcolm Gladwell's 10,000 hour thing, but this is the science behind it. There's two things to expertise. There's automation, which has now been revived with functional MRIs that show as we're learning a motor skill that we essentially move these movements from our cerebrum to cerebellum. We automate movements, and as we do that, we're able to divert our attention to other tasks that are necessary at the time. So that's one thing, one of the major factors in expertise. The second is something called chunking. And this is seen in chess players, or well studied in chess players. And if you take a master chess player and show him a chess board, he will very readily reconstruct that board from memory. If you do that to a club level chess player, he'll do it much less frequently. But if you take that board and rearrange those pieces into a random organization that can't actually occur in a chess game, then those three groups perform equally, regardless of their level of skill. So it's not that the master is more intelligent, it's that the pieces on the board have a great meaning to him. And he's able to see that in a moment and deduce a lot of information from it. So what was once accomplished slowly, the master now sees immediately. And this actually has been borne out in neurosurgery as well. A lot of these studies are done with gaze movements. If an expert or novice microneurosurgeon observes a case, their gaze movements are different because they observe different things. Now, this is a standard learning curve. We hear a lot about learning curves. People use the misnomer of a steep learning curve. But learning curves actually are all sigmoid. It's just a matter of where you are on that sigmoid learning curve. But during the course of any learning experience, you have a curve that looks a little bit like this. And as you're learning any task, I think it's probably a series within the sigmoid curve of this quote unquote bumpy learning curve. I think I'll be useful to our audience because I'm probably somewhere here, or at least I hope by now I'm somewhere here in this over the first bumps, but a long ways to go. When Dr. Marcos asked me to give this talk, I went back and looked at my own experience and where I've started. Now, admittedly, I didn't do a very good job of documenting those type 1 complications, the atelectasis or new AFibs, but these were what were in my clinic notes of my skull base cases. And in my first 4 years, I've accumulated 130 cases, and I identified 19 real complications in 16 patients. And those complications are similar to what you'd expect in a skull base series, including infection, CSF leak, positioning complications, venous infarct, arterial injury, and a number of cranial neuropathies. This number I don't have included in the 19. And these are permanent palsies or severe paresis. I didn't count the transient or the House-Brackman 2 cases. But then when I looked at who they were, I said, you know, that patient did well. And ultimately 15 of the 16 patients in which I had complications in had what you would call, or at least what I felt, was a good outcome. But I knew a lot of names immediately off the top of my head that did not have good outcomes or did not have an outcome that I was satisfied with. So I went back and looked at the patient's names, and I did find about 9% of cases that I wish I could have it back. I wish I could take another strike at that case. You know, I asked myself, well, what did I want to do different? And in 4 of those cases, it was the approach. 2, I think, was a knowledge failure. 5 was a lack of persistence. And 2 were technical judgment. And I think 1 or 2 of these, the numbers don't add up because a couple of them had more than 1. And when I looked at the I want it back cases, only 3 of them were in my complication set. So that means that 9 of those cases, you know, didn't have what you'd define as a complication, but I'd really want that case back. I'd want another try. And then I asked myself, well, would my mentor have done better? And I granted myself a handicap of time, right? I think probably all the cases my mentors would have done at least as well and faster. But there were 15% of those cases that I really think my mentor would have done a better job with. The patient would have had a better outcome. Many of those were cases that I wanted back. But you can see there's at least a 6% difference that I did the best I think I could do at my level, and I think that my mentor would have done better. And obviously that raises some ethical questions for everybody in the early practice. But I think that's what I found in my series. Now, 10% of the cases overall, I failed. I thought my mentor would have failed, and I feel like it's something that the field needs to do better with. In my series, I saw 5 common skull base surgery failures, and that's CSF, vascular, cranial neuropathies, thromboembolic, and incomplete removal. And I think if you look at most series published in the literature, you'll find a similar set of problems. Now, I think that as for complications, one of the better summaries of avoiding them or managing them is actually in my father's operative atlas book titled on the first page, Listen to Me. As somebody who spent a childhood of not listening, I think the remainder of the talk I'll go through and show how I've carried that into my career somewhat. Now, number 17 on that list was learn from others. It saves you a lot of grief. 20, eliminate intraoperative surprises, extensively extract all the information from preoperative studies. And so the days before a case, I think, are just as important as the days of the case. The day of the case, you study imaging. This is a young man that we were planning a middle fossa for an acoustic. And you see he has an aerated petrous apex, setting you up for a CSF leak. You know, I get CTs on every acoustic neuroma, and I know a lot of neurosurgeons don't, but the extra study, I think, probably saved him a complication of a CSF leak. Additionally, study every study that's performed. This isn't a skull-based case, but this convexity meningioma had an angiogram to understand the sinus anatomy. But, you know, I got a cheater out of it. I learned the exact vascular anatomy of the blood supply of the tumor, and that set me up to devascularize it very quickly. I also spend a lot of time, you know, now there's a wealth of resources, of videos. I spend the days before a big case watching every video I can find, whether it's on operative neurosurgery or YouTube. I might go to the lab. The night before in bed, I rehearse the case in my mind. I think of every step that I might do and what pitfalls. I go back and look at my last case of the same to prepare for this case. The second is the day of. And I think the day of, the most important thing is for you at that time, the whole world is that operating room. You know, we all have the anesthesiologist that's ready to go home to his family. We're ready to go home to our family. You know, when I have a major case that day, I tell my wife the night before I won't be home for dinner. If I am, great, but don't expect me. And I tell the room when we walk in, hey guys, I'm buying dinner tonight. And that just sets the mood of the room. There's no anxiety, because I think as I teach these couple girls as we go on our hikes through the desert, the most dangerous part of a hike is on the way down the mountain. And they don't listen to me like I don't listen to my father. And, you know, we get all our bumps and bruises on our way out. Next, the days after, the postoperative care is as important, is as important as equal to fine surgical technique. DVTs are one of our Achilles tendons, and we're malignant about getting our patients out of bed, no matter how dizzy or nauseous or miserable they are, ambulate them. You know, cranial neuropathies need a very careful management, and you know, a facial palsy postoperatively can mismanaged can turn into a blind eye. And so caring for the postoperative care of our patients is at the core of what we do. The details matter to the tail of the last suture, and that's what makes a lot of the difference. You know, these are two relatively tough tumors that I'm very proud of. Both these patients did very well, but this patient on the left was positioned in a park bench position because of cervical spondylosis, and he got pectoralis muscle atrophy from that positioning, which has never recovered. This patient on the left got a gluteal atrophy that since recovered fully, but for him it was probably the most uncomfortable part of his postoperative care. I think we touched on this a little bit, but you have to be a plastic surgeon and you repair defects with vascularized tissue. This is Sam Savavi-Abbasi's paper, which shows just about every vascularized flap in the head, and I'd encourage you to pick it up. I'd encourage you to study the plastic surgery flaps that are out there so that you can preserve and prepare them for your cases. Veins are more vital than they are usually believed to be. Preserve them. This was the first Petroclival Meningioma that I faced, thinking that I was ready. I had had a fair number of tumors under my belt, and I think very good training. You know, I wasn't careful enough with the Lebet complex, and she had a Lebet injury. She was very drowsy and goofy for the postoperative period, and started picking at her wound. And she started picking at her wound in that confusion, and she got a wound infection. She got a wound infection, and she later got a craniectomy. And so, you know, these complications compound themselves. So avoid the first mistake. She ultimately did well, but you know, I found myself here on the learning curve. I don't want to discourage you. I want to encourage you. This was my next case, and you can see this temporal lobe looked great. So I worked my way up the learning curve a little bit with this one. I want to go back to the most dangerous part is the hike down and touch on a few others with this this certainly my worst surgical complication. And that's that I had this bad petroclival meningioma. We were facing it late in the night. I knew I was leaving residual. The surface with the brainstem was poor. I had already made that decision and was debulking a little bit more, maybe with my mind not in the perfect place, and I injured Aika. She had a very serious stroke involving both her brainstem and her cerebellum, and had a poor outcome, and so quickly found myself back on this part of the learning curve. We worked our way back and tried again and learned and have gotten better at these, have gotten maybe a little wiser and learned our patients and learned that, this part of the tumor, we might not be able to dissect that. And it's okay in this circumstance. We certainly gave a good effort and got a good result. And then I just want to finish on those first two acoustics that I started on, and kind of in that theme. And in between them, I think you can see in my giant acoustics kind of the way through this curve. Starting with that first guy that we got a good picture and a bad face, to this woman that we had a good face and a bad picture. And then we learned maybe not to get a perfect picture, but got great faces, and leaving small residuals behind when necessary or when the tumor allowed us, completing the job. And so I think that's my time, and I'll stop there for questions.
Guys, this is absolutely spectacular. I think this is I don't know if the audience appreciate the subtleties of everything you said. I really commend you on a very well put together talk, very profound. There are many subtleties, and I commend you particularly because of your stage in your career. It's really a talk that should be given by a very senior person. The material you put in it, it echoes very well. And thank you very much for the effort you took in putting it together. Let me see. I think Mike McDermott has either some questions or some comments. Mike, why don't you tell Keith what I think you were
I agree. It was a very thoughtful and mature presentation, Keith. So thank you for that. You mentioned the aerated petrous apex. If you were doing a retrosigmoid approach, how would you treat that any differently than if the petrous apex wasn't aerated?
Well, I think if it is retrosigmoid, you may not get in it, or you may not unroof the top of the canal, and so avoiding it would be good. We still did the case middle fossa. We were just prepared for it. We placed a fascial graft in it, but the problems not recognizing it, whether if it's on a pre-op CT, that's fantastic. If it's in the OR, at least you probably would have recognized it still and been prepared and repaired it then. But.
Yeah, I want to know whether you, Jacques, or Christine, when you do a retrolabyrinthine approach, posterior petrosectomy, do you preserve the pericranium and the temporalis fascia together posteriorly in order to be able to rotate a vascularized flap?
I do. Are my slides still up?
Down
yes.
There. I started doing that because I got so tired of CSF leaks after.
Petroso. So this is what I do now. This is temporalis muscle. This is temporalis fascia that I leave pedicled There's actually a beautiful paper about the middle temporal artery vascularizing this.
Mhm.
So I push the suboccipital muscles down, temporalis muscle forward, and I use this, and it fans over the whole middle fossa and mastoid, and I love it. I think that's one of the few things I modified from how I learned how to do this.
Yeah.
Christine, you want to comment on various ways of covering our temporal bone stuff?
Yeah, so I'll dissect the soft tissue along the temporalis line all the way to the zygomatic root. Sometimes I'll drill the zygomatic root to just allow the temporal parietal fascia flap to flip in without having any pressure on the vascular supply. I generally, if I really need to cover a huge defect, then I'll take the temporal parietal fascia flap and also take some pericranium as well. And that along with like abdominal fat and some well-placed sutures, been pretty happy with the closures.
Very positive comments from the audience. They really enjoyed it. Experience makes you humble, things like that. So they have enjoyed all the talks. Any other questions? I'm afraid Ashok is stuck in the OR, so we can conclude now unless somebody wants to say anything else. Well, maybe I can ask Mike, my brother in seniority. Mike, what would you say at your stage and my stage is the thing that makes you most nervous? What type of case? I mean, in spite of our experience, nervous may not be the word, but what worries you the most about developing complication in what kind of case?
Right. So I'm older than you are. So
I didn't want to say it, but that's
fine.
okay.
That's fine. But I always, I would tell I kind of joked about it with my colleagues a little bit, but not with the patient, that a big Petroclival Meningioma is a lose-lose situation. I mean, if a patient walks in with a little bit of unsteadiness, like it's got a 5 centimeter Petroclival, even without brainstem edema, it's a very difficult case. 100% of those patients come away with at least there's Ashok, at least some transient, new neurologic deficit, whether it's transient double vision, facial numbness, conductive hearing loss from the bone work and packing the mastoid with, I don't use bone wax, I use absorbable bone wax. So I think that's the most difficult. And even on the biggest Petroclival meningiomas, since I need all the help I can get, I'll do an angiogram to look and see if they can take out the ascending pharyngeal or an occipital branch, something like that, that'll help me with the blood loss. And I learned, I think, that with the really big ones, when there's a significant supratentorial component, I cut the fourth nerve. I never tried, I know this sounds terrible to say, but I didn't try and save it, because once you work on it, both sides, subarachnoid space for hours, it doesn't work anyway. And it slows down the operation so much. And my ophthalmologist was able to do some eye muscle surgery post-op, and the patients had, very good congruent vision. So I think Petroclival is still the hardest tumor that we deal with.
Yeah, I agree with you. Particularly there is brainstem edema and all that. I agree. I can't think of a kind of a worse case where so much is at stake, particularly when you start with a decent neurologic exam.
Yeah.
Does anybody do that as a staged approach? I've been doing that more staged, where we do the approach like a day or 2 days before, and then we'll bipolar all the door and remove the vascular supply. I feel like it gives it a day or two to make the tumor softer for you guys to dissect out. I don't know if anybody has any thoughts about that.
I tried it a couple of times. It depends on the neurologist. And it depends on the working environment. If the neurologist is experienced and fast, but they're teaching, then we don't sit down. At least I wasn't sitting down until like 2:30, 3 o'clock, 3:30. And that was hard. And then I tried the staged approach, like Tom Rigitano had recommended. The first time we did that, the patient got an infection from a CSF leak. So I stopped doing that. And then I asked the neurologist, which to advocate what one of our old general surgeons used to say after 6 p.m. And he would say, there will be no teaching, only learning, which meant that he was going to do the operation and you were going to watch. And you can learn by watching.
Sure. Ashok, I see you're here. Are you able to give your talk? You're muted.
Yeah, sorry to come so late. And
No, you came just in time. You're just the last speaker, and we've been talking about you the whole hour and a half. We're saying how wonderful you are. Now prove it.
I find that hard to believe, but let's hope this all works okay.
Sure.
And I was just reading some of the commentary happening on the side here about about experience and how many cases it takes and these type of things. And I think, I sort of went through it more philosophical than in my approach to talk about complications than strictly speaking about specific complications. So I think you'll understand a little bit more as I go through the presentation. I'm just going to share the presentation. Give me one
take your time. I see one question from the audience. So go ahead and share your slides. Let me ask it. Let's see. Jacques, Mike, Kaith mentioned that he studies pre-op. Do you watch YouTube videos, study up, etc.? What's your method with a tricky case?
Anything I can get my hands on. Operative neurosurgery, the skull-based journal, all of them have done a wonderful job of collecting video cases, and then I have my own stash of Dr. Spetzler's and my dad's cases from my training, and so I just try and find something similar and look at it.
And if I can suggest, particularly, any age, young or old, looking at your own videos. I mean, I remember Spetzler even in his last year saying how many wasted moves he was making when he edits his own videos. We all do it, of course. And studying your own videos. Yes, of course, study your mentors and masters, whatever, but look at your own videos and be self-critical and say, what the heck, why did I move this tissue this way? What did that achieve? Nothing. There's a lot to be learned from self-reflection and watching your own stuff too.
I would say edit your own videos.
Yes, correct. Right.
Because the editing process really teaches you just how much you wasted,
Exactly. That's how you do it. Yeah. Ashok, I think you're ready. If you put it in play mode instead of navigation mode, you can go ahead. Perfect. Thank you.
Perfect. So it's a funny conversation that everybody's having, because the conversation pretty much, I hope I can wrap up a lot of the conversation we're having through my slides, because as I said, I think that we think about complication avoidance or management in surgery as some type of event that happens in surgery, and how do we compensate for it. But in reality, it's so much more, So what I did was I stepped back and I said, well, what is it about complications? What are the different areas that we think about? How can we talk about complications and sort of break it down to the different areas in which all surgeons can develop? What am I focusing on, and as I continue my practice as well? And so, I broke it down into 5 major areas, and I think a lot of the conversation that we're having falls into these different areas. And I wanted to give some examples as we go through. Obviously, there's so many techniques to manage complications and avoid them that even a 2-hour seminar is not going to go through everything. But I think obvious areas are prevention, which we'll talk about. When a complication is happening, how do you recognize it? Whether it's in the operating room, or as is often the times with skull-based surgery or with vascular surgery, how do you recognize that the surgery itself or post-operative or perioperative complications are developing, especially because, our big nemesis, spinal fluid leakage, problems with CSF leaks and things like that. And then, of course, you know, the million-dollar question, of course, is always, how do we mitigate it? How do we resolve that? Whether it's the acute vascular event during surgery or the post-traumatic or post-operative sequelae, how do we go about trying to identify and then manage the problem? You and I have discussed on a personal level many times and about discussion, right? Like, how do you actually discuss this with patients and make sure that you divulge complications properly and appropriately, not necessarily, you know, falling on the sword and saying that this is a complication and it's my fault, because a lot of complications come from the inherent pathology that's present. And then finally, reconciliation, and that's what we were just talking about. You know, how can you actually learn and improve? How can you do those types of things to move forward? So I think this must have been mentioned already. You know, we were talking about how many cases does it take to become an expert. Of course, you know, Malcolm Gladwell wrote about this for many professions, about the 10,000 hours of rehearsed practice. When we talk about rehearsed practice, what are we talking about? We are not talking about simply hours in surgery. What's funny about what Malcolm Gladwell wrote here is that if you do 4 hours a day as a neurosurgeon, then 10,000 hours, you'll become an expert at that. I don't know any neurosurgeon who does only 4 hours a day, so that's a good thing that we won't have to spend as many days becoming experts in our areas. But certainly, I think the concept is rehearsed practice. So having some type of coaching as well, and whether that is self-coaching, as Kate had mentioned about looking at surgical videos, or you had mentioned, and others have, about looking at your own videos to see how you can improve efficiency, how you can improve surgical technique. I think those are all very important things. But it takes that rehearsed practice in order to become an expert. The next thing, you know, we're very fortunate here at UVA. I have an anatomy laboratory, which, you know, we have 15, 18 stations here. But it, you know, what's interesting is I teach all of those laboratory sessions, the skull base approach sessions. But in fact, I'm learning more from the skull base approach sessions than probably, you know, the residents and the medical students are. You know, I enjoy doing a standard retrosigmoid approach, looking for nuances to approaches that I can sort of utilize, whether it's anatomic correlates during surgery. You know, what are the small nuances in the shape of the bone and the impression of the venous sinuses? And I just put this as an example, but, you know, this is sort of the thing that I still do on a monthly basis. Even if I don't have a surgery, I go down to the anatomy laboratory and pick a surgical approach that I do, and I do it with the residents from skin to skin. You know, here's a retrosigmoid approach I was doing with them, you know, bringing in endoscope. So everybody's interested in endoscopic, minimally invasive approaches. So I wanted to learn a little bit more about how does that look compared to my standard retrosigmoid approaches. But I think rehearsed practice, not only in the operating room, but also out of the operating room is critically important, so that we aren't having complications in patients when we practice, but rather we're demonstrating our excellent ability when we finally get to the operating room. The next thing I would say is, how can we avoid complications is through really critically analyzing imaging. You know, there are so many things on the images that can even, you know, prevent small complications or make you not even worry about certain complications. Even on a standard retrosig for an acoustic, you can see emissary veins that you can drill out properly and maybe coagulate before it goes into the sinus, right? And not worry, why do you have a mysterious thrombus in your sigmoid sinus or transverse sigmoid sinus? Because you're not doing it properly, right? Also, you can say, okay, do I have to worry about a CSF leak or not? In this patient, there's no worry about a CSF leak for a retrosig approach. Likewise, you know, you study the anatomy very critically on the preoperative images. And these are not things that I think that it's not just a large acoustic that you're going to do. You're going to do a large acoustic with a cystic lesion. cystic tumors may be a little bit more adherent, and also it sort of makes the facial nerve a little bit more difficult to delineate sometimes. And so certainly I think understanding that is of importance. And then the most important thing I find is when you know something is going to happen, it's just behooves you to anticipate those complications. And also, you know, you seem like a soothsayer if you actually do a proper history and physical examination. So this patient, I didn't show the IAC, but, you know, he had what looked like a typical large vestibular schwannoma, except the patient had, you know, cardinal symptoms of a facial neuroma, right? So he had issues with altered lacrimation and dry eye, altered mucosal membrane and moistness. He had a little bit of a metallic issue or taste alteration on that side of the tongue, and a little bit of facial twitching. So it's important to recognize what, you know, pathology, it's not all just a retrosigmoid for an acoustic. And if you anticipate that and prepare the patient, obviously it's not a complication. And you can also compensate for it properly. You know, we ended up doing a 5-7 after removing this guy's facial neuroma. He did very well after surgery, and that slight rest facial droop has been corrected with the static facial sling to support his 5-7 anastomosis. And finally, it is understanding the disease. This is a patient, you know, with NF2, obviously. You can see right here in the geniculate ganglion right here. So you can see the enhancement bilaterally. The patient had a little bit of facial weakness bilaterally before surgery. But it's also important to understand that these tumors in patients with NF2, right, are not just tumors of the vestibulocochlear nerve alone. So this is an example of a case I bring up, understanding the disease and sort of catering the surgery to try to rationally say, what are we going to do? So this is a young kid who came with a new diagnosis of NF2 when he was having problems ambulating and surprisingly a little bit of unilateral hearing loss. And so I'm going to scroll through his MRIs. This is an axial contrast enhanced imaging. You can see very giant left vestibular schwannoma. On his coronal imaging, you can see a Falk's tumor. You can see the obvious hydrocephalus, but you also see a glimpse of a tumor down in the cervical region. And we can see it much better here. In addition to his vestibular tumor, he also has a spinal schwannoma that is severely impacting the cord. And just below that, he has almost a holochord ependymoma. And so in thinking about, you know, NF2, I think one of the things that I say is that it's very difficult to treat a biologic disease such as NF2 with a knife. It's like, I remember John Popp, I think, wrote a editorial a number of years ago about how the neurosurgeon tries to defeat glioblastoma with a knife, you know? And I think that sort of goes here is we have to pick our poison as to where are we going to emphasize our approach. And so, you know, one of those things that I think about is not only, you know, how do we master the surgery? How do we become masters of surgery like yourself? And how do we try to refine our technique? It's also contributing to the knowledge that exists. And when we start noticing things in our laboratory, which is our patients, you know, is trying to understand the disease better. In this situation, I began to study NF2 patients quite critically, and this is an image on the left here showing a 8-year-old boy with NF2. You can see the multiple discrete tumors in the right internal auditory canal in this patient. And you can see even on the left side, you can see a couple of small tumors as well. Sorry. And so what happens in these patients, we are all used to the cluster of, you know, it looks like a multilobulated mass when we go for surgery. But what is that that we're looking at, right? And what it is multiple tumors coalescing together. That's what is going on. And so we proved that by removing tumors piecemeal, doing genetic sequencing of the individual tumor lobules, and showing that each of the tumors were actually discrete. This is sort of the reason why early proactive surgery to remove small vestibular schwannomas in patients with NF2 with the hope that you can have lifelong cure in that ear was met with 50 to 60% recurrence at 10 years, even after that's the data from the House Ear Institute, is because you're trying to defeat the biology of the disease. And so when we see something like this and we understand it, we have to sort of manage anticipated complications. So in that patient, that I saw, with that giant acoustic and with this compression of the cervical cord, what I decided to do for him was remove all of the tumor in the posterior fossa. And at the same sitting as well is essentially in a form of an extended or far lateral approach. I went and removed the hemilamina of C1, 2, 3, and also removed the intraspinal portion of his schwannomas all at one sitting. That's the big problem with these patients is it's playing catch up, right? And so while we can't remove everything, now if you notice on some of these images here, let me see if I can go back and show you. One of the things I like about NF2 surgery is the critical importance to notice lower cranial nerves with tumors on them and avoid them at all costs. So in this patient, we went down, took out the vestibular tumor all the way down to the lower cranial nerves and made sure to skip over 9, 10, 11 as we went down into the spinal canal and avoided injury to those as we went ahead and debulked and removed at least the intraspinal portion of the spinal tumor. So, in the end, after 6 months after the surgery, I went and did a midline myelotomy on the man. He was 18 at the time, and we took out his spinal cord tumor, his ependymoma, and he's moved on to obviously trying to manage his disease with systemic therapies. So, understanding the disease, critically important. I say that because it's equally important for us to avoid complications, unnecessary complications. And it's not just unnecessary complications from surgery, and I'm sure you all have talked about this maybe, is here's a man, he's 58 years old, and he presented with dizziness and some hearing loss. You can see his speech discrimination score is 72%, his recognition threshold is 10 decibels, and he still has very useful hearing in that ear. We know that through the study of natural history of acoustic neuromas that a subset of patients are not going to progress. And so in these patients, when we do unnecessary interventions, I consider hearing loss from this type of surgery on this tumor, or even treating it with radiosurgery and having edema. These are unneeded complications if we don't do the due diligence of observation. This is now 3.5 years later. The image on the right is 3.5 years later. Patient is happy, has had no progression of his hearing loss, and certainly there's been no tumor progression. So I think we have to understand that complications are not just the things that we have in the operating room. They're based on what we decide to do, even from the get-go. So I know that you all may have really been focusing a lot on usual, skull-based complications that we see. I presume CSF leaks. I presume vascular injuries. I know there's a few videos I've seen of miraculous reconstructions of vessels that you've done, and so I assume that those have been discussed. I wanted to show a case. This is an esthesioneuroblastoma here. At UVA, we tend to really believe in the neoadjuvant treatment, so we treat them with preoperative radiation and chemotherapy. So this is 6 months before surgery, and then you can see that the tumor has shrank. So left side, you can see the tumor, and then this is post radiation chemotherapy, and then he's getting ready for surgery now. As you can see the reduction in that. And so I'll play this while I talk about it. The surgical approach. We did a standard bifrontal approach, and then we did a transfacial approach as well in order to try to do an en bloc resection of the majority of the tumor. Now you can see that the tumor also extended back into the orbital apex, and so we went back, took out all the tumor, essentially back to the level of the tuberculum, and so. When we reconstructed it, we used a full dermal thickness graft from the thigh, placed that in for reconstruction, and initially did very well. And so you can see that full thickness graft. I don't know why I lose my cursor sometimes. Let me see. Give me 1 second here. And so yeah, so we have a full thickness graft there running from the region of the cristagalli to the tuberculum, and then on top of that we have a pericranial graft and some fat, and we've sealed up things very well. You know, of course, with these type of surgeries, I like to put a lumbar drain to avoid undue retraction on the frontal lobes. And after surgery, he woke up and was doing well. Day 2 and 3 became a little bit more somnolent. And of course, what's happening is he's accumulating more and more extra-axial fluid and air, and his brain is sagging. I think we've all seen this, you know, due to lumbar drainage. We removed the lumbar drain and did a blood patch. And as soon as we did that, within 12 hours of placing the blood patch, patient woke right up, did very well. And you can see his image now on the right side of the screen. His brain completely filled up the entire cavity. And you can see that the graft is pushed down into place. And he had no issues with CSF leak. So taking that, you know, I'm just going to show quickly, in the interest of time, another case. One of my partners, I think we were starting to talk about staged surgery. One of the concepts that's coming up is, you know, staged surgeries for these tuberculin meningiomas as well. This patient had a endoscopic approach, had an internal debulking of his of what turned out to be a hemangiopericytoma. Wasn't a planned stage surgery, but due to excessive blood loss during surgery, you know, because of the nature of the tumor, they really didn't feel comfortable going and doing any type of extracapsular dissection. And so after they closed up, after they, the image on the left is the pre-op and the right is the post-op. And so I waited a little bit and then did a transcranial approach for that surgery. And thank goodness they did not try to do an extracapsular approach and try to dissect it off the chiasm. I looked at this tumor 10 different ways and could not remove it from the optic chiasm. The shared blood supply was just too much, I felt. And so in that situation, I left a small residual, and then the patient did well initially. And you can see post-operative day 1 had a lot of air. I like to use, as I said, lumbar drains on most of these cases. The patient woke up, but became progressively somnolent over the next 2 or 3 days. And I said, oh, it must be just lumbar drainage. We got a scan though, and the amount of air is reducing, and the brain is actually expanding seemingly. And so, you know, to evaluate it further, got an MRI, and indeed, you know, she was developing small multiple infarcts throughout her brain. Cerebellum, you can see it in the posterior mesial temporal lobe there as well. And, you know, I had to do a bit of research for this as well. And it turns out it's the same issue. Lumbar drainage has been associated with ischemic events and also distant hemorrhagic events as well. And so the mitigation in that situation was just, again, doing a blood patch. And within overnight, I had the blood patch the next day, neurologically doing perfect. So for this lady, you know, for that residual tumor, we did fractionated radiation for that hemangiopericytoma. And although I sit and sort of wait for that recrudescence to come, it has not. And it's been 4 years now since that post-operative radiation dosage, and her vision is still good, and she continues to well. She started as a 38-year-old, is now 42 and a half years old. So, you know, I have a couple more cases I wanted to go through, and I'll try to do that in the next 3 or 4 minutes here. Next thing is tuberculin meningiomas. I think what I wanted to really emphasize here is no matter how many, and Mike is probably, you know, he's published on so many of these, right? Mike, I think you had a series of 100 or something like that you published on. Mm-hmm. I find each one of these, you know, to be a challenge, of course, but you know, they generally do very well. The dissection is meticulous, but along the optic chiasm goes very well usually. And you can see, I put up the axial imaging here to show you, you know, how to look for the course and try to plan for which approach to use with regards to orientation of the optic nerves. So you can see them clearly on the coronal images here and make a strategic plan to remove tumor. This patient did extremely well. Now, having said that, other cases, I think sort of the enemy is comfort or sort of a little bit of complacence. For this case, even though the tumor, what I felt was in a cleft inside of the side of the tumor here, I went through, I did a bifrontal approach on this one. I thought I had released the optic nerves beautifully from that cleft, and I went back all the way to the chiasm. There was a small portion of tumor that I could not get to behind the right internal carotid artery, but everything else removed. And I left all the vasculature on the chiasm. And unfortunately, this patient woke up with complete afferent pupillary defects. And I think it sort of is a demonstration of hubris that no matter how good you think you may have become, that there is always room for improvement and evaluation, self-evaluation. Now, as far as complications and discussions with family, can I say that honesty and having the integrity to be able to talk about complications is of so much importance. The top image is a family in which I did it was actually not a skull-based case. It was just a glioblastoma patient. Post-operative day 4 was getting, I was going to send him home day 3 morning, and day 4 he had a hypertensive emergency and had a massive hemorrhage, and the family, he didn't make it, and so the family, I went and spoke to them. It was at 2 a.m. We made decisions, et cetera, et cetera. But in speaking to them afterwards, they have actually set up a research fund in which they are promoting the study of glioblastoma and supporting research here at UVA. The bottom picture is a devastating complication I had. The gentleman there that's actually holding my son became hemiparetic and partially aphasic because of my management of an en passant vessel in a giant sphenoid wing meningioma. That patient I saw every day, this was when I was at the NIH. And so we didn't have rehab. We just did rehab at the NIH. He was in the hospital for 2.5 months, saw him and his family every single day. And then, this was 14 years ago. We still call. He still texts me every holiday. I get a text. I get family updates. It's okay to be honest. It's okay to be close with your patients. I think that's important. The last thing I wanted to highlight is reconciliation. This is what I mean by that is, learning from your mistakes or learning from your previous operations. This is a patient who gave me the opportunity to learn on herself. This is a young woman who had an optic nerve caprenoma, and you can see that here. She had presented with an optic pathway. I say pathway because she had a nerve caprenoma, but the hemorrhage extended into her chiasm. You can see the hemorrhage extending into the tract itself and going nearly all the way to the geniculate. I did her surgery, did a right terional approach, did a Sylvian fissure split, removed I opened the optic nerve, felt like I removed the caprenoma and evacuated any of the residual hematoma. 2 years later, she had moved to Utah for school, and she represented again with a small hemorrhage, flew back home, and I saw her, and she had this obvious rehemorrhage from residual caprenoma. So I went back, just as you all have suggested. I went back and I went and watched my video. This is at Harvey Cushing. This is what he used to do, right? At the end of his operative day, he would go home, he would eat dinner with his family. And then at 6:30 at night, if you read his monologues, what he would do is sit there and draw meticulous drawings, what his mind, he didn't have a camera and operative recordings. He sat down and made beautiful drawings to learn from in the future and to teach us. And that's sort of is something I learned early on, is to watch those operative videos. So I went back and looked at my operative video from her first surgery, and I said, what could I have done better? And, you know, certainly exposure is one of the arts of skull-based surgery, getting a better exposure, a more wider exposure. Certainly I saw that as a limitation. And then I also saw what most of us might have in the optic nerve is I was tentative the first time. And I said, look, these are the things that I can't be this time around. And so when I did her surgery the second time around, did a bigger, wider sylvian fissure split in order, and I'm going to speed this up a little bit for our sake here today. But after we exposed and you know, had the optic nerve more widely exposed, you know, opened up the optic nerve here, you can see here. And on the imaging, I noticed that the Caprenoma and the hematoma had extended all the way to the arachnoid on the other side of the optic nerve. And so on this approach here, did an, you know, a full anatomic resection of that Caprenoma, and you can see all the way through the optic nerve. You can see the mesial part of the optic nerve is spared here, but the entire lateral part had the optic Caprenoma in it with the hematoma, and it was completely resected, and you can see it right there. And so this is, you know, the post-operative imaging on her afterwards. I think the important thing, I think, you know, Dr. Drake said it best, is, you know, you have to be honest with yourself to the point that it hurts so that you try to learn. You know, he did that with basilar tip aneurysms, and sort of, that's how the refinement of technique happens, not only in yourself, but in the profession of neurosurgery, is learn from yourself, teach others, and try to become better. And Jacques and all, thanks for giving me the opportunity to catch up and speak today.
Well, I am so glad we didn't miss your talk. We were just about to miss it, thinking you'll be in the OR, and this was spectacular, Ashok. Thank you. Again, we've had a series of spectacular talks. Very true. Again, very important details. You know, I gave a talk a long time ago. You know, we all say forgive and forget. I say no. The title of my talk was Forgive and Remember. Whenever we have a complication, you forgive yourself, you forgive whoever caused it, including yourself, but remember. And it will be stored somewhere in your memory. It'll keep resurfacing when you do a next similar case. So this is, yeah, this is excellent. Let me see if there are any questions. I don't see any specific audience questions. Mike, or any of the panelists, any comments on this excellent talk by Ashok? Any thoughts?
No, I mean, those are, I mean, that optic nerve for chiasm cavernoma is, you know, a difficult situation no matter what. So,
you know, we just published a series of 5 of them, and I was flabbergasted. I have a video somewhere. I removed one. I was left with like almost a transparent caved-in optic nerve. Vision improved from 20/300 down to 20/30, and the ophthalmologist got all so excited. So I agree, Ashok. It looks daunting. It looks you're going to blind the patient, but remarkably, they get better from removing the mass effect. Sorry, Mike. I interrupted you. You're going to say
yeah,
something.
no.
Yeah. Anybody has anything else to say? Otherwise it's 7:08 p.m. We've had spectacularly lovely feedback from international people watching us. As you know, these sessions are recorded, and people will come and do come and watch them later if they've missed them. Thank you all very much. I really enjoyed this session greatly. All of you, we will see you in 2 weeks. Next week is Thanksgiving. Enjoy Thanksgiving if you're celebrating it. Otherwise, we'll see you December 3rd. Be safe. Bye, everybody. Thanks, Ashok and everybody.
Thanks, everybody.